So before we get started, the first thing I want to say is just a very quick comment about the title of the talk. The title of the talk, Barriers Reaching Carriers, is intentional and maybe a little bit confusing, so I want to quickly touch on my thought process behind that, because we don't talk about people being carriers of disease, and I certainly don't think that people who suffer from HIV, especially in the Southeast, should be stigmatized any further by being called a carrier of a disease. But I do think it's true that people who are stigmatized and marginalized by HIV in the Southeast are carriers of a lot of other things. And they're carriers of shame in some cases. They're carriers of marginalization. They're carriers of poverty. They're carriers of social chaos. So there's a lot of things that we do need to pay attention to. So it's a little bit of a play on words, but I hope it does draw attention to the fact that the lives of our patients are very, very complicated in ways that most of us don't even begin to appreciate. So the second quick comment along those same lines is that there is a tension, a little bit of a tension in this talk. There's a tension between balancing the needs of our patients who look to us and need for us to be the people who help them focus on their strengths, the people who empower them, the people who emphasize that they do belong to a community, the people who emphasize that they can have a place to go to get good care, and the tension between our needs as providers to look at the evidence sometimes in a way that is objective but isn't mistaken for blaming the victim. So I do want to recognize that today and point out that we are going to resolve that tension with compassion, with empathy, and with understanding. So if I talk about evidence, if I talk about an article or something like that that doesn't sound like I'm being compassionate about the needs of a patient, please don't misunderstand that. We're simply looking at the evidence and trying to figure out how better to help our patients, actually. So here's the question. The question that keeps me up at night is, why do we have, in 2016, 45,000 new HIV infections every year in this country? We have the medicine that we need to suppress the virus. And as those of you who've been taking care of these patients for a while know, we have significantly decreased the pill burden. We've significantly decreased the side effect burden. And we're moving rapidly towards integration of agents into single-dose formulations. We're looking at injectables now. So lots of different opportunities out there to take care of people and prevent transmission. We have the barrier protection necessary to minimize transmission of the virus. We've had that for a long time. But there's social issues, there's intimacy issues, there's all sorts of issues with the barrier protection, but it is there. And so we have those things in our armamentarium of things to help us with. And we also need to realize that for most of our patients, for a lot of the patients that I take care of here in Tennessee at least, HIV is no longer a biomedical challenge. In other words, when a patient comes in and sees me, we probably spend 20% of our visit time talking about HIV and 80% of our visit time talking about poverty, chaos, mental health issues. So that to me is a significant piece of information and something worth exploring further. But we have the tools to minimize transmission of the virus. So why do we have 45,000 new infections a year? Well, one of the places that I look to answer that question are some of these things that you can see highlighted in red on your slide. These are the things that I've looked at in my research into HIV behaviors. And so you can see that relative to the general population of community-dwelling adults in the United States, our patients have higher rates of depression, they have higher rates of impulsivity, horrifyingly higher prevalence of childhood sexual abuse, shame and stigma associated with that, as well as with having HIV, and lower levels of the ability to provide for their own needs. And all of those things that are highlighted in red are associated with increase of risky sex behaviors. So you've got a huge problem here, and these are some of the reasons that we continue to have 45,000 new infections a year. And focusing on these and understanding these, I hope, can help us come up with new plans and programs to minimize that transmission and lower that number. So the first thing I want to do is, as we dive into this, is break up the talk for you and show you how I've got it organized. Do something scary and show you a little bit about how my brain works. But what we're going to do is we're going to divide the talk into three different categories, and you can see them there on your screen, three different categories that all impact a person's psychological adjustment. In other words, their abilities to respond to stress over time. And then I'm going to make the argument that people's ability to respond to stress over time, the psychological adjustment piece, has an impact on their safe sex behaviors or their intention to use safe sex practices. And the three buckets we're going to talk about in this order are social and psychogenic factors that impact a person's mental health status, life history factors, and then HIV disease factors. So we'll take a look first at the social and psychogenic factors. And the first piece of evidence I want to present to you today is a slide from a study that I did here in this clinic probably 3 years ago now, to take a look at the burden of psychological adjustment problems in our patient population. And what you're looking at are the data that show that across 10 different domains of psychological problems that this screening instrument I used looked at, there were significant inverse correlations or reverse relationships with self-efficacy in this population. So basically what that meant, if you look across the slide, you see alienation and negative affect there at the top. In our population, people who had high levels of negative affect or depression had very low levels of self-efficacy. So the relationship is not when one is high, the other's high, which is what you want. It's when one is high, the other's low, which is what you don't want. And then you can also see, reading across the rows there, that almost 50% of the patients in our sample of 250 had concerning levels of depression. 40% had high levels of alienation, and almost 3/4 or 74% had high levels of social withdrawal. So those are all clues that we may be onto something to be looking at these kinds of problems in our patients to try and find clues for helping our patients. And we'll return to this at the end of the talk. The next thing I want to do is introduce a couple of terms that I hope you're familiar with. If you're not, they're very important terms for you to be familiar with. The first of them is structural violence, and this is a term that has gotten a lot of traction over the last 10, 15, 20 years and is increasingly part of the conversation. It is a recognition that there are barriers to equality built into the institutions that we use to run our lives. There are barriers to equality built into the law sometimes. That may not always be explicit, but they're there. There are barriers to equality that are built into access to social services sometimes that we may not see if we don't encounter that barrier ourselves. So if it's not a problem for me, I don't recognize that it's a problem for somebody else necessarily. But we do know that there are these barriers that exist. Fortunately, we no longer live in a world or in a society here in the South, East, where racial discrimination is legalized the way it was until the recent past. But that doesn't mean just because something is illegal and there's no longer blunt discrimination that there isn't subtle discrimination. So we have to pay attention to the fact that our institutions are not equal, and there are biases that are built into all of the institutions that we use to navigate our daily lives. And the second thing I want to talk about is a concept called allostasis, and I'm going to introduce that concept by talking about my fish, and Jen is smiling because she likes my fish, and I like my fish too. So the fish are here to make a point, and the point the fish are here to make is to contrast two different ways of looking at human health. And the first way of looking at human health is through a concept called homeostasis. And homeostasis is the traditional medical model for looking at human health. And the way you would use that in a sentence was, or the way you would use that conceptually, a person is said to be homeostatic if their internal environment, if their vital signs are normal. So if the organism is functioning stably from the skin in, then that organism is judged to be healthy. So if my blood pressure is great, if my heart rate's great, if my pulse is great, I'm healthy. And that's great as far as it goes. And what that has to do with fish is going to become apparent in a minute, but what I want you to think about is the limitations of the idea that you can assess the level of a fish's health by looking at that fish, or you can assess the level of a human's health by looking at those vital signs, because as we all know, and we don't think about it with ourselves as humans because we're just oblivious to the fact, but the fact of the matter is, just like the fish live in aquariums, we live in societies, and society is our aquarium, I would suggest. And so what we all know about the fish is you can't just look at a fish and say, okay, everything's great. You have to look at the aquarium. You have to look at the social environment. And so this newer concept of allostasis has to do with the stability of an organism in the environment. So you don't just look at the vital signs of a person. You look at how that person is functioning in their overall situation, and you begin to recognize then how the overall situation, how the environment, how our very large and to a lot of us largely invisible human fishbowl does in fact impact the health of some of us, unfortunately more than others. Because here's what happens to fish when you don't pay attention to their environment. And I would suggest it's not that different from what happens to humans when you don't pay attention to our environment. It's just a matter of us not recognizing the environment because we're so used to functioning in it. I doubt a fish, if you could ask a fish what their environment was, they would be completely oblivious to it as well because it's all they know. But the concept of allostatic load measures the wear and tear over time that occurs to people who are marginalized, who are daily having to deal with the ramifications of these unequal institutions. And the thing that's important for me about this slide that you take away is the point in the your lower right-hand corner there to remember as providers that people who live in a toxic environment will over time develop toxic responses as survival mechanisms, and you can never afford to let yourself be in a position where you feel like a person who's bringing that toxicity into the exam room is pointing it at you. You have to be able to step back and understand that that toxicity is a learned response to a toxic environment, and it's your job to help people back away from that and develop more positive ways of dealing with the world, but it doesn't help that situation if you just assume somebody's mad at you or somebody's ugly at you and you take offense at that and shut down. So the next concept we're going to talk about is this concept called the social determinants of health. So now that you've got a framework that includes allostasis and structural violence, you can understand the social determinants of health. And this is a concept that was initially published by the World Health Organization, and it's a list of 10 different social aspects of our lives as humans that impact our health. And you look at that slide and you go, gee whiz, that's old news. Well, when it was published about 20 years ago, I think now, it was completely revolutionary because, again, everybody was in this homeostatic mindset where if you just look at vital signs, then we know health is okay. Well, the World Health Organization took the lead and published this document that is becoming a standard now to recognize that there are a variety of social factors that do impact human health, and we as providers of all stripes, professionals of all stripes, have to be able to navigate through all this in order to help our patients maximize their own living. So what I've done here in order to get my head around this is take all 10 of these and organize them into boxes, and we're going to talk a lot about uncontrollable stress in this talk and some of the ways that uncontrollable stress impacts having HIV. So you can see that of the 10 social determinants of health, 6 of them have to do with the impacts of stress on human health. And the impact of stress on human health is something that we're only beginning to understand, but it is a very large impact. Other things that the social determinants of health look at is early life health, the long-term impact of low birth weight and extremely low birth weight as infants. That's an impact that follows you throughout your life. A lot of our pregnant women with HIV are at higher risk for this kind of outcome. Lack of access to a healthy diet, food, nutrition obviously impact health. Addiction issues, and thank you World Health Organization for recognizing that alcohol and tobacco should be grouped with illicit substances and are not the casual substances we often assume them to be and market them to be here in this country. And finally, transportation as a social determinant of health, and the World Health Organization's definition of that has to do with a focus on walking and cycling and better public transportation. Here in the Southeast, my take on transportation as a social determinant of health has to do with the percentage of our patients who can't get to clinic for care because they don't live on a bus route, or the percentage of our patients who ride a bus for 2 to 3 hours here in Nashville to get to the clinic, maybe because they fell and are in acute hip pain, or they've got a fever of 102 and probably have a pneumonia and they're stuck on the public bus for 2 to 3 hours in order to get here for care. So that's my interpretation of transportation as a social barrier to health. And then again, the last thing, the takeaway thing for me here, the message is that all of these barriers, all of these determinants, all of these things that impact our health are all choices that we make. And I don't think we think about that enough. We don't think about the fact that the way our society is organized is not predetermined. It did not drop down from heaven pre-organized this way. And all of us have opportunities to change the way our society is organized for the benefit of the people who are marginalized by our social organizations. How does this impact HIV? Well, this is my spin on this. This is something that I think those of us who do clinical care all day long sort of this is a trap that it's very easy to get stuck in. And let me just walk you through this graphic real quick. It's a hard thing to make and to simplify into one slide. But the problem is that a lot of the individual disease symptoms that our patients manifest are related to structural factors in the environment. For example, skin infections and uncontrolled blood pressure due to lack of antihypertensives. There's uncontrolled blood sugar due to lack of ability to keep insulin safely. So those kind of things cause disease symptoms, and then disease symptoms can't be addressed because people don't have access always to a safe place to keep their insulin. People don't always have $3 to have a medication. People have to choose between what medications they're going to have what month. That's a reality part of our lives here. And there is sort of this really corrosive back and forth between the structural factors and the disease symptoms, and you find yourself trying to get in the middle of that, and what we sometimes lose sight of because we're fighting that battle at that level to try and get the insulin or try and get the blood pressure medicine or try and deal with the cellulitis or try and deal with the fact that the patient has 3 teeth left in their mouth. We lose sight of the fact, the other things that go on in this. And the other things that go on in this, I would suggest for our patients, are a decreased sense from the patient that they can control anything in their life. Because everything is this whirling swirl of chaos, and everything is, every single thing that happens feels like it just triggers 10 more bad things that happen. And so you get into a vortex that just keeps spinning further down and further down and further down. People lose a sense that they can control their lives. People lose a sense of hope for themselves, and that's been shown to increase the likelihood of risky sexual behaviors. And that's one answer to why we continue to have to deal with these 45,000 new infections every year. And I wish I had an answer for this problem. I wish we could write a prescription and fix it. If we could, we already would have, and we wouldn't be giving this talk. But what I want to do is try and increase awareness, try and open people's eyes to think even more in those clinical encounters about some of what's happening at the lower level of this graphic and ways to make a difference there. You can't always fix everything that's going on in this vortex between structural factors and disease symptoms. In fact, 10 times out of 10, you can't fix all of that stuff. But you'd be surprised at the difference you can make in a person's life if you step back from that vortex and acknowledge their frustration and their pain and try and do a little something to instill in them some self-confidence and some self-efficacy, and hope that working together you can maybe improve the quality of their life. So a couple of other social factors that we're going to talk about, I want to present some evidence for related to how our social life impacts HIV. Here are 3 different categories of evidence from a review of the literature on how housing status impacts people with HIV. This is a whole talk in and of itself because the numbers are phenomenal. The numbers are depressing. The government, federal government, estimates that 50% of people with HIV will sometime in their life have a housing crisis. 50% of our patients will have a housing crisis at some point in their life. And that's not just a situation that can be easily or quickly resolved. Here in Tennessee, here in Nashville particularly, it's a complete nightmare. You could give every homeless person in Nashville a Section 8 voucher today, and they would still be massed in the streets because there's no housing available. And that's actually an intentional choice that's made by our legislators. So these things that people decide do have an impact on other people's lives. But you can see here that there's at least 3 ways that not having stable housing impacts HIV outcomes. And the first of these is adherence. So people who have unstable housing are much, much likelier not to be taking their medications than people who do. Just anecdotally, last week I saw a patient who has been off her ART, her antiretrovirals, for probably 3 to 4 months. She's homeless, she's middle-aged, she has hypertension and diabetes and severe depression. She cannot live with her daughter and her granddaughter because their housing would be lost if she moved in with them. So she's couch surfing with family members, and she's not taking her medications because the family members, while she's asleep, go through her purse and look at her pills and say, aha, you've got this, you've got that, you have to leave. So that is just one example, but what we were able to do for her, just to give you a suggestion of a remedy, is we were able to work with a pharmacy here that we collaborate with and have her medication put in what's called a bubble pack, so she could have access to her pills without any labels put on her medication, so nobody knows what she's taking, and she can have a little punch card she takes around with her medication. So hopefully we can do a little bit something about that. But the impacts are real. People who are co-infected with hepatitis C have a greater risk of problems with their HIV and hepatitis C if they're homeless. And then not surprisingly, in the risk behavior category, there is a greatly increased risk of sex exchange behaviors for people who are unstably housed. People who are unstably housed are, in that study, 5 times more likely to engage in transactional sex as those who were housed. And of course, a person who's housed has a lot fewer reasons to engage in transactional sex than a person who's not housed. And if I need to make a point, as I'm sure you can imagine, people who are engaging in transactional sex are not in a position of power to negotiate condom use. And that's one of the reasons that people prey on them, is that they are powerless and they can't demand that a condom be used because it's not an equal, respectful situation. It's a survival behavior. Food insecurity is another social issue that has impacts for how HIV is transmitted and how HIV care is delivered in our population. And this is another slide that could be one whole talk in and of itself. But you can see that food insecurity impacts HIV care, of course, along nutritional pathways that you might think of, well, that makes total sense. You might think about food interactions with HIV meds, with some people needing to take some meds on a full stomach but not able to get a full stomach. Obesity, lipodystrophy are problems. Another thing that's not on this slide is ART side effects related to food and GI issues and unmanageable diarrhea. Diarrhea is a miserable condition to have to try and manage while you're homeless. It's one of the most humiliating things I think a person can go through. It's a real problem. Food insecurity can also lead to anxiety and depression, which, as I've made clear, also are pathways to drug and alcohol use. There's not a lot of data that I could find, at least, on levels of food insecurity in our society. The one study that I did find, and don't have a slide on in this topic, suggests that only 15% of our population are food insecure. And based on the work that I've done here in Nashville in our homeless and socially marginalized populations, I would question that. I would say that's highly underrepresentative of reality, but I would also say that there's in our society a lot of shame and a lot of embarrassment associated with affirming food insecurity. So it would make sense that that number would be low. From an institutional perspective, it would also behoove you, if you're interested in this, to take a look at the SNAP program, which is the official acronym for what we commonly call the food stamp program in our society, and see how scant or how small the monthly benefit is for the average person who gets food stamps in this country. I don't have any patients who have food stamps that provide nutritional food for 1 week out of a month, much less a month out of a month. So just because we have a program doesn't mean the program meets the need, and I think that's a gap that we can all help our neighbors understand better, especially our neighbors who aren't involved with the kind of patient care we do every day. The other way that food insecurity impacts HIV care is obviously not taking your medications, missing clinic visits, having treatment interruptions. All this can be impacted by people who are having to spend their time because they don't have a choice looking for food rather than remembering to take their medication every day. And so all these treatment interruptions, of course, end up with worse viral suppression. They end up with lower CD4 counts, increase in morbidity and mortality, and to the theme of this talk, also an increase in people who are more likely to transmit HIV, which goes back to the 45,000 infection a year question. This is some data from a study looking at the relationship between food security and HIV viral suppression in a small sample of patients in San Francisco. So you can see there are 4 categories of food security. I won't bore you with all that, but categories 1 through 3 mean that you have either complete access to food or some access to food. Those categories were lumped together and compared with people who basically had no access to food in this study. And you can see the pill adherence, 62% versus 38%, people who had food versus didn't. Virologic suppression, 63% versus 35%. And what's telling to me also is a provider in this population is that there's much greater history of drug use in people who have no food security, and a statistically significant higher rate of depression in people who have no food. And that's the Beck Depression Inventory, the BDI, which is a commonly used tool to measure depression. So you can see depression was significantly higher, as you would expect, in patients who don't have access to food, and it makes a real impact in how they're able to care for their own HIV. So we're going to shift gears and talk about another social factor that may help us understand a little bit more about why we're facing this ongoing epidemic, and that is sexual behavior patterns. And this is an interesting topic that we don't necessarily talk about enough. There are some articles that are out there. I'm going to go through some evidence about that, but this is not something that a lot of us are comfortable talking with our patients about. We should be. I would like for us to be. How we talk to our patients about that is a subject for another talk, but it is important that we do address these topics with all of our patients. And one of the things that I've learned over time from my patients is that there is a clear pattern in our patients around condom use, and that pattern has to do with the fact that condoms are used with casual partners and condoms are not used a lot of times with primary partners. And that has to do with the fact that a condom, the choice to use a condom or not use a condom, has to do with an expression of intimacy and an expression of trust between two individuals. And that it can also communicate, unfortunately, a level of distrust between two individuals to ask about using a condom in a situation. So it can complicate relationships, and one of the subjects of my dissertation work is to look at that problem, and it's a very real problem. But it's important for us to realize that people make choices for a reason sometimes, and we need to learn to work with patients and respect their reasons and find ways to help them be safer, but understand that there is a choice that somebody is making when they don't use a condom. The other thing to understand about sexual behavior patterns that people may not be aware of are a phenomenon of serosorting and seropositioning. These are terms for the phenomenon that you see sometimes in the MSM community of people who feel like, if I have HIV and you have HIV, well, we both already have HIV, so what difference does it make if we have unprotected sex? That's very commonly seen. A lot of us who are providers in the clinical setting spend time every day educating patients to the problems of this assumption, but it's an assumption that's commonly made. It's an assumption, much like a lot of this other stuff, that's facilitated by technology because there's no master editor of the internet, and so somebody puts something like this out there, somebody else sees it and interprets it as fact when in fact it is not fact, and it becomes pseudo-fact. So very, very, very complicated things to have to navigate through. But there are, as we all know, significant problems with people who both have HIV having unprotected sex. And we won't go into what those are, but we know there's problems. I will say that we know that HIV is not the only STD that's out there. And so a lot of our patients who both have HIV and are having unprotected sex are still coming into the clinic for care for a lot of other STDs, which is an issue in and of itself. Seropositioning is an interesting phenomenon that's a recognition of the fact that the greatest risk of transmission in sex between a person who has HIV and a person who does not is for the person who is receiving. So the person who's the receptive partner is at a higher risk of transmission receiving HIV. So if you have a situation where one person has HIV and the other doesn't, well then if you look at that piece of information, then you would logically interpret it to say that the safest way to have unprotected sex is for the person who has HIV to be the receptive partner and the person who does not have HIV to be the inserted partner, but that still is not risk-free, and that's a community, that's a culture, that's a subpopulation's interpretation of a fact that actually is not a correct interpretation of that fact. So, but those phenomena are out there, and if you start to ask people about that, you'd be surprised that this may not be something we talk about a lot, but it's very, very common knowledge amongst most of our patients. A couple of slides here that I don't want to focus on too long because I don't think these slides tell the whole story. I don't think these slides tell the whole story at all. Everybody is familiar with the continuum of care, and I'm not going to talk about that, but we all know that there's a great gap between the percentage of our population who's diagnosed and the percentage of our population who's virologically suppressed, and that's a very frustrating part of doing HIV care. But you can see that African Americans, this is data from the CDC, are less likely to have their virus under control than our Hispanic or white populations, and that, in my mind, has to do with the fact that we're sloppy about how we use race definitions in research, and we make lots of assumptions, and that actually, skin color is a proxy for social chaos a lot of times versus a judgment that somebody, because of the color of their skin, is less or more genetically able to handle taking a medication or not, which I think is just patently absurd. So we're going to push real quickly through this. And then we also know that people who are younger are less likely to have their virus controlled. So that, again, that's information that we have, but that's not information that tells the whole story. If you want to tell the whole story, then I would ask us to look at what's called sexual networks and look at the impact of skin color and look at the impact of age on sexual networks. And there's a very facetious question at the top of this slide. I'm sorry, I couldn't help myself. But the fact of the matter is that sexual intercourse is not a random behavior. It's something that most people, most of the time at least, most adults most of the time, have the opportunity to make some choices about the people with whom they have sex. If that weren't the case, we would live in a completely differently organized society where people just bumped into each other and literally sex occurred, which obviously doesn't happen. So it makes sense, recognizing that there is intention between sex partner selection, to look at sex partner selection. And so there's a study, an older study now from 1999, having to do with skin color. It's the Lauman study, and what this person did was they took a look at an African American community and a Caucasian community of sex partner choices, and the peripheral versus core designation has to do with how likely a person was to have sex, and that was measured by the number of sexual partners. So a peripheral person in this study has very few sexual partners, and a core person has a lot of sexual partners. And because of the social organization of African Americans in large cities in many parts of our country, it's just a fact that people who have few partners are more likely to bump into people who have more partners than are Caucasians. And that fact, in and of itself, by 30% increases the likelihood of an STD. So, again, that's information that I hope is a little bit more expansive way of thinking about some of the problems we face every day, that people don't always have choices that we may assume they have by where they live and by who their community is. And the other point about this, as I would say as an HIV clinician, is that even a few people who are, in terms of this study, defined as core, who have uncontrolled virus can have an enormous impact on an overall community's level of virological suppression. The other things that we can look at here in terms of sexual behavior patterns, this is a study that looked at two groups of men who have sex with men and two groups of heterosexuals, one male and one female. And you can see that the men who have sex with men groups were more likely to be in a new relationship in the past year. They were much less likely to be in relationships that have lasted over 5 years. And this is an interesting slide. They were also much more likely to be in relationships with partners who were either greater or lesser age of them by 5 years. So there's more age discordance in men who have sex with men couples than there are in heterosexual couples. And then there was a greater percentage of people in the MSM samples who were in concurrent relationships. And none of this is to judge any of these behaviors, because I don't judge any of these behaviors, and I hope that you don't. But if you don't recognize these behaviors, then you're not providing the kind of care that I hope we're all providing. So this maybe provides a little bit more perspective on some of the reasons that the CDC has that data that say that African Americans are less likely to have their virus controlled and younger people are less likely to have their virus controlled. Life history factors, we're going to shift now. We're going to push a little bit more quickly through the last two sections of this talk. Life history factors having to do with stigma and shame. Stigma and shame are two closely related but different concepts. Stigma, it's important for you to understand that stigma is resistant to change, because stigma is something that's imposed on a person from the larger society. Therefore, it is hard to change something that's imposed from outside. It's tightly linked with structural violence. Shame, by contrast, is something that's internalized and hopefully maybe, not always is, but may be amenable to change. So that construction helps me understand the difference between those two concepts. And what does shame have to do with what we have to talk about? Well, shame has a lot to do with it because of the horrifyingly high percentage of childhood sexual abuse in our patients. And there are two studies you can see in this study, which was done in 5 southern states, 8 clinics. Over half of the people who were asked reported severe physical abuse or sexual abuse. And you can see it's not that different between men and women, and a quarter of the sample was sexually abused by the time they were 13 years old. And the other study that I was able to find that took a look at this, higher numbers, almost half reported one sexual assault since they were 15 years old. And the other thing that's terrifying about this is that the average number of events was almost 10. So this is not something that happens once and you have the opportunity to process it and get over it, or get through it, perhaps is more accurate, get through it and continue your life. It's something that continues to happen and becomes a pattern, and each time it happens, it has a greater corrosive effect on your physical and mental health. So I began to wonder when I saw that data, why don't we talk about childhood sexual abuse in clinic? And I went to see if there were guidelines about this, and I found that there are not guidelines. There's guidelines for asking about current partner abuse, but there's no guidelines for asking about childhood sexual abuse. And so this is the result. This is a study that looked at primary care physicians responding to a mailed survey of about 300 docs, and 80% of them who believe that the rate of childhood sexual abuse in women is greater than 10% only screen 30% of the time. And of those who believe that the rate of childhood sexual abuse in men was greater than 10%, only 41% thought that was the case, and they only screened 32% of the time. So people, number one, underestimate the prevalence of this problem, and number two, are not aggressively screening. And the good news about this, if there is any good news out of this, is this slide where you see that people who were correctly aware of the prevalence of childhood sexual abuse were over 2 times more likely to screen than people who weren't. People who were confident in their screening ability, confident in talking about this touchy subject, were 2.5 times more likely to screen, and people who believed they had a job, it was part of their clinical care role to screen, were almost 12 times more likely to screen. And the good news in all that is that knowledge of prevalence, confidence in screening, and perceived role to screen are all things that we can address through educational programs, and we can improve our skills on as clinicians, and we can begin to make a difference in the lives of our patients. There is also data, there's a couple of studies here, they're older but they're important, that show that there are physiological links between shame and HIV outcomes, that show rapid CD4 cell decline in people who were more sensitive to rejection, people who had swifter CD4 cell declines if they had a attitude that was more self-blaming relative to others. You know, this is more than just feel-good stuff. This is important stuff. It has physical ramifications. This is another slide that shows that. We're going to skip pushing through that, and then we're going to talk briefly about this study that was actually done in our clinic. This is a subset of a much larger study that was done, and there were interviews with 32 patients here in our clinic a couple years ago, and these were the stigma themes that were uncovered. And you can see there that self-isolation is used as a coping mechanism, and self-isolation is a behavior that feeds depression. Self-isolation is a behavior that increases the likelihood of risky sex, and the discrimination not only by people who you don't know, but discrimination by people who you do know, including healthcare providers, is a huge issue in our community in 2016. HIV disease factors. This is, to me, the most novel part of the talk, and we're going to talk about some different ways of looking at our reaction to stress for a couple of minutes. And so the traditional way that we understand how stress impacts human health is through what I'm going to call cortisol centrism. And this is the link back to the social determinants of health, the SDH, because if you remember that slide, 6 of the 10 social determinants of health had to do with stress and had to do with the impact of stress on human physiological and mental health. And so our traditional understanding of this is that we have this what's commonly called a fight or flight response to stressful situations. It's driven by cortisol, and what happens when that's released into the bloodstream are a number of things happen. They're listed there on your slide. People are running away from mastodons is just one example of how my ancestors used to deal with this. But the physiological problems you can see there are actually adaptive mechanisms that help people fight off an attack, a physical attack. So the blood becomes hypercoagulable. So if you're traumatized, you don't bleed as much. Blood sugar and fat is dumped into the bloodstream to be used as emergency fuel, and anxiety and aggression are increased to respond to a threat. So all that works really great if you come into your cave at the end of a long day and you find a saber-toothed tiger there. Then you have an immediate reaction to the tiger, and one of you is going to be the winner in that encounter, and then one of you will go on. But what we have in the 21st century is a different kind of response where the problems aren't saber-toothed tigers in our caves, but the problems are long-term social marginalization, poverty, homelessness, rejection by community of birth, rejection by community of choice. And so these same physiological responses that 50,000 years ago were extremely useful have become extremely problematic now, because what you see is you see all the problems that are listed there at the bottom, and they're not hard to imagine that they would be problems if you let those systems run a long time. But the long story short is our bodies haven't adapted to turn off those mechanisms. And so a lot of these mechanisms, again, to go back to an earlier slide, lead to disease factors that we spend a lot of our time in clinic trying to fix, but we can't fix because we can't turn off the underlying system that's driving the problem. So this is our traditional understanding, and what I would like to ask today is, what if there was another way of looking at the world rather than just saying everything is just a response to this fight or flight system that used to work and maybe doesn't work so well? That's a great place to begin, but I would suggest that it's not the only place to look for clues to helping our patients. And so what I'm looking at, what I'm interested in now, is a newer theory called the polyvagal theory of responses to stress. And this model, and there's no way I can communicate this in one slide, but long story short, what the model suggests is that there actually are 3 response systems that we have developed over time, 3 evolutionary levels of responses to threat. And the first response is actually a social response. So our first response to threat is to respond with our facial muscles. So we respond to threats or we respond to acts of kindness by expression. And so if expression doesn't work, we hope it does, and for those of us who are relatively empowered in our society, facial expressions work most of the time. If facial expressions don't work, then that's when the fight or flight response kicks in, And if that doesn't work, then that's where the most primitive response kicks in, which is just total shutdown, total immobilization. And there are cases of that. There's evidence for that. Fortunately, it's not frequently seen. But this is a different way of looking at the world, and there's a lot of evidence. We could talk for hours just about this. But how it's important in terms of our patients is to recognize the fact that a lot of the nerves, again, that have to do with responses to stress are nerves that are wired to our facial muscles. And so that makes it important for us to appreciate the role of facial recognition in social situations. And so if you live in an environment where a person's expression is trying to communicate something to you, then the success you'll have in that environment is contingent upon your ability to interpret the signal of their face. So what evidence shows, unfortunately, is that in our patients, there's a deficit of correct interpretation of facial expressions. So that means, and perhaps it's an explanation for the fact that some of our patients, no matter what they try, just can't get along, just can't seem to get through life, always feel like they are being misinterpreted, always feel like they're being misheard, always end up getting in arguments, aren't successful navigating our institutions for care. Well, there may, I'm not saying there is, but there may be a physiological explanation for some of this that we may not be able to fix, but I would suggest if we had the opportunity to explain some of this to our patients, if it bears fruit over time, people might be empowered by understanding that there's a disease-related component to what's going on, and they might be empowered by understanding they need to maybe take a breath before they decide what another person is telling them by their facial expression. And there's 3 studies that I'm citing here that have evidence that backs up this assertion. I won't read the slide, but these are only 3. These are 3 of the more recent. It's a fascinating area for research and for even clinical care. Again, it may be a situation where what we have to do sometimes is just recognize that something is a problem, like we do with short-term memory, like we do sometimes with peripheral neuropathy. We can't fix these things, but sometimes people are relieved to know what's going on with their bodies, and they're not going crazy, or they're not falling apart, or they don't have some cancer that they imagine themselves to have because they have neuropathy. So in my experience, you really can empower people by just explaining them the reality of what's going on. And what I'm trying to suggest very briefly here this morning is that the cortisol-centric approach may need to be supplanted or enhanced by some of this newer data that, again, looks at the role of how we've evolved as very social creatures to communicate with each other without using words necessarily all the time. And then there's some data out here that shows that people have better virological response to medications, and we're not going to push through that because I want to have time to take some questions. But this is just more supplementary evidence of the same phenomenon. And then finally, I want to return back to the evidence that we started the talk with. So I hope that I've been able, through this very quick talk this morning, to put some ideas, seed some ideas, seed some thought, and hopefully seed some interaction and seed some actually action, which would be the best, to help our patients find ways to deal with the complex challenges that get in the way of their successful management of HIV and continue to contribute to 45,000 new infections every year in this country. So you can see, if you take a model that looks like we started at social factors, life history factors, and disease factors impacting psychological adjustment, you can see that the social determinants of health and behavior patterns and shame impact social factors of living. Shame and childhood sexual abuse impact a person's life history, and then childhood sexual abuse, which I didn't speak to the fact, but it's also been shown to damage the same area of the brain that is attacked by HIV, that has to do with lack of facial recognition responses. Childhood sexual abuse and brain changes from HIV disease factors, all these things fit into this construct that shows an increase in adjustment problems, and then finally, at the very far end of that model, a decrease in safe-sex behaviors. So here are a few pearls for you. I always like to try to end my talk with a couple of pearls, because I feel like my talks are always downers, and I want to make sure that people leave with hope and engaged and not with frustration. So the number one thing for me is to recognize the role of mental health for all of our patients. One of the challenges of mental health for all of our patients is that a lot of our patients don't even recognize or won't recognize that there are mental health issues to deal with. We can see them as clear as day, but until a patient sees them, it can be difficult to engage them in care. But I think, and I believe it, and I try to act on it in my own practice, is I try to make sure that everybody who I care for has access to those resources. We have to recognize when people come in the room that they have a tremendous burden that we don't have as their providers in terms of being on the short end of the institutional stick. They don't have access to services, don't have access to programs, don't have the self-efficacy to successfully navigate through the programs that are out there always. The programs that are out there, just because they're there, they're not sufficient. Food stamps is not sufficient. When there's no Section 8 housing in the community, it doesn't matter how many vouchers you have. We have to be, as providers, better advocates for our patients regarding childhood sexual abuse. We have to have some courage about having that conversation. We have to have a tool set in our back pocket, though, and be very careful when we raise this conversation with the patient, because you're going to cause more harm than good if you raise this conversation with a patient and you don't have a solution to their pain when they decide that in response to the question they want to share the pain of their abuse with you. So make sure when you ask this question that you have resources in your community or in your clinic to get people into care, even sometimes in a crisis environment, because a person who comes into your room looking completely normal isn't always, and you may be opening or peeling back the scab that uncovers a world of pain, which I think we should be doing, but I want to make sure when you do that you have the resources to meet that need. And then finally, as regards to polyvagal theory and new ways of looking at facial cues and facial nerves and stress responses, I think we all have an obligation to continue to engage in knowledge from other fields outside our own and deepen our understanding of the complexity that we humans are, both as biological and as social creatures, and take advantage of learning from other fields to help us improve the care of our patients. So thank you very much for your time. I appreciate everyone's attention in calling in. I'm always glad to take questions. Slides will be available on the website, and I'm always available. That's my cell or my email if anyone has any questions they'd like to discuss offline.
Wow, even gave the cell phone. Thank you, Rob. We appreciate that very much. I would not consider this talk a downer when you describe it. I think it's good that we look at the reality of what we need to deal with, and I really appreciate that you're giving us all this information today. And I know we have some questions, so we're going to work our way down through the questions. I'd like to start with asking sort of how you start to develop the relationship with a patient where you can get at some of these really sensitive topics. Like, how does the topic of childhood sexual abuse come up? Is that something that's going to flow into part of the sexual history? Is there something that they might say that triggers you kind of digging a little deeper in that? Can you talk a little bit about that?
Yeah, that's an excellent question, and unfortunately there's not an algorithm for that. That's not the kind of thing that you always know you can walk in and say on the first visit. It's appropriate that it should be part of the sexual history, but it's not always appropriate to ask that on the first visit, because the goal of the first visit a lot of the times is as much about building trust and communicating empathy as it is about gathering information. So actually one of the worst things I think you can do in a first encounter is just walk in a room and start barraging questions at a person. The other thing that I find in my practice helps me be able to get to these issues over time is to make sure people know that I'm addressing the issues that they believe are important in our clinical visits, and that if a person comes in and they have an issue, then we're going to talk about that issue. It may not always be their A1C. It may not always be uncontrolled hypertension. If they haven't eaten in 3 days, we got to talk about a sandwich. And if a person comes in and hasn't eaten in 3 days and you fuss at them because they're not controlling their blood pressure, then you're not going to get to sexual abuse as a child.
Okay, and I want to make sure that everyone knows the lines are open for questions. So if you have a question, you can click on the hand icon and we can open up your mic and you can ask the question live. You can also type any questions that you have in the Q&A. We're getting some of people are asking again about when will the slides be available. They will be available on the website, and let's see, we have a few questions we're looking through here. So there's a high percentage of new infections among MSM, and I know you talked about this a little bit in the beginning of your talk, but if you could just kind of talk a little bit about what you think might be fueling the social determinants there. No, that's a whole talk in itself.
Well, it is a whole talk in itself, but it's a very important question because the fact of the matter is that social determinants do just as much as biological determinants have to do with the transmission of HIV, and I would suggest that a large part of the social determinants have to do with people feeling powerless, people feeling marginalized, people wanting to find a way to express themselves in a society where they lack that freedom. Here in the Southeast, there is a staggering and heartbreaking amount of stigma associated with sexual choices, and that is a great fueler of the epidemic as well. So those are all huge problems.
And we have another one up here kind of related to the child abuse and neglect. So are you aware of any studies or therapies or interventions, if you are aware of something when someone is very young, that you can help to reduce their risk for HIV?
You know what, one of my colleagues sent me an email link yesterday about a therapeutic intervention for children, and if you will send your email address to Clint or Jen, I'll be happy to forward that to you. But there are interventions that are beginning to be more inclusive, that are beginning to look in more whole ways at this huge problem in our society of childhood sexual abuse that by no means is just confined to people with HIV, but I know of at least one programmatic option I'll be happy to send you. The unsaid thing about childhood sexual abuse is that while the rates are horrifyingly high in our population, with 50% of our patients suffering from this, that's double the rate of the general population, and the horrifying thing about that is the realization that 25% of us, 1 out of every 4 people you see every day, suffers childhood sexual abuse.
Yeah, that's an alarming statistic.
It's an alarming and terrifying statistic that we don't talk about.
And we can, when we send out our follow-up email reminding people to evaluate this presentation, we can include that link. So if you wanted to send that to us, we can send that out.
I want to respond to Rebecca's question, which is excellent. Do clinicians ever use the ACE tool? And that is a tool that is a survey, basically an instrument that measures adverse childhood experiences. And there's a lot of work being done around that tool. There are other measures of childhood sexual abuse that are out there, but I'm a big proponent of that tool. I haven't integrated it into my practice here in this clinic yet, but I think it's only a matter of time, and I think yesterday would be a great time to start.
That's great. And we do have someone asking about if you get a certificate for attending this, you can just email Claire Bowles, and she can send you a certificate if you need one for this talk. We're working on getting CME for Webcast Wednesday. We don't have that just yet, but it is coming. So very soon we will have CME for these presentations. Rob, just as a final question, can you talk about any tips that you might have for providers as they get into these delicate subjects, how to kind of leave them at the office and not internalize this stuff and take it home? I know that it's really a tough question, but I think it'd be helpful if you have any tips.
That's an extremely tough question. Because I don't know that there is an answer, because I don't know that any of us who work in this field do that. All of us should, shame on all of us, self-included, for not doing a better job at that, and I'm the first person who used to roll his eyes when people in nursing programs talked about self-care. But the fact of the matter is that the problems that I'm talking about are not problems that any of us individually can solve. And they're not problems that will be solved in a day. They're problems for our society to solve, and I think to work in this field, you have to be at peace with the fact that your role is to make what change you can, to be an advocate for change at every level that can occur, and to be present with your patients in the suffering that they're going through, and to recognize that that does have therapeutic value and that you do have therapeutic value, but you can't get so lost in the suffering of any one person's horrific suffering that you lose the ability to take care of all of your patients or your family or your friends or anybody else.
I think that's a great spot to end on. Thank you so much for being here today. We appreciate it. Thank you, everyone, for tuning in, and we will see you next week.